Okay, so
Hello,
I hi, how are you?
good and you?
Good. I'm just gonna start because I don't want to keep anybody past an hour. Fingers crossed. Um, but yeah, um, just definitely put your SFCID number into the chat for me. Okay. So, I know there's like five main chapters that we have for this final for Dr. D. And she said that each like topic or each question is a exam question. So, for example, like how I have one where it says definition of gender-based violence, that would be considered one question. And if you like, they all equal 50 at the end, and there's 50 questions on the test. So, um, that definitely makes sense. Um, so the first thing that I saw was the definition of gender-based violence. And I took the definition from the textbook, from the corresponding pages, and I found that it's a term used to distinguish violence which targets people or groups of people based on their gender from other forms of violence. It includes acts that result in or are likely to result in physical, sexual, or psychological harm, such as rape, torture, mutilation, and sexual slavery, forced impregnation, and murder. So essentially, we're talking about violence towards a group of people based on their gender. I don't remember what specific page I got this from, but I think I got this actually from one of the beginning pages where they have the vocabulary, and I saw it there. So gender-based violence is one of the definitions that we need to know. Um, Then the next thing that she wanted us to know was what would be an example of secondary prevention for intimate partner violence. So based on what we know about secondary prevention, what would you say would be an example of a secondary prevention technique for intimate partner violence?
Assess patients for bruising and injury.
Mm-hmm. Right, an assessment would be secondary. Um, as well as screenings, right? Because screenings is secondary. So we can screen them for intimate partner violence. And something that I also saw, I think I saw this in the ATI. It was not specifically in the textbook, but I saw under an ATI under violence, and I think it was under levels of prevention. I saw assessing and evaluating any unexplained bruises or injuries. So I figured just in case Dr. D doesn't mention the typical example we've been thinking of as screenings, I provided this example as well that I thought could be used. Um, the next thing that I had, which would be another question on the exam, which would be about intimate partner violence, tertiary prevention. So, what would be an example of tertiary prevention that we could do for someone experiencing intimate partner violence?
Providing counseling for them.
Yes, counseling, support groups, rehabilitation centers like mental health services are examples of tertiary. I also found, I believe, in the violence section as well, that resources in the community, making sure that any resources in the community are readily available for survivors is also tertiary. So I put two examples that I thought would be very pertinent, but I most definitely think for secondary, it would be screenings from Dr. D, and it would be, like you said, counseling or support groups or mental health services for tertiary prevention. Because remember, secondary means that um, this might be starting somewhere. They might having to start with it, but it's not at its peak. Whereas tertiaries, they have or are going through whatever the said thing is. In this case, it's intimate partner violence. And now it's at the extreme, and we want to make sure we can do whatever we can to help them um, through this traumatic experience, and that would be counseling, support groups, and mental health services, or making resources in the community readily available for survivors. So, another thing that she said is Dr. D wants us to know um, safety planning in relation to intimate partner violence. And she said I copied this directly from the intimate partner violence sheet that she gave us. And it said that these are the steps that may save the life of a woman and her children. So the first thing that she wants us to do in safety planning is identifying the partner's use and level of force so that you can tell when you and your children are in danger before it occurs. She also mentioned that typically abusers use the same method, so they're going to keep doing that method. So the first thing that we want to do when we're thinking about safety planning is asking them, what do they do? What sorts of violence do they implement towards you, so we could see the pattern to know what will trigger it, and we can try to keep them safe. After that, we are going to identify safe areas of the house where there are no weapons. So definitely not the kitchen. And there are ways to escape. So after we figure out how the violence is going to occur, what method they use, we want to find a safe area to go and a safe area to leave if they can. The next thing would be, let's just say they couldn't get out and the violence does occur. We want to make yourself a target. So she said to dive in a corner and curl up into a ball with your face protected and your arms around each side of your head and your fingers entwined to cover yourself from injury. If possible, the next thing she said is to always have a phone readily available and know numbers to call, and don't be afraid to call the police. If you can, let trusted friends or even neighbors know your situation and have a signal to let them know that you need help. Keep a bag packed with money, extra set of keys, copies of important documents, extra clothes and medicines in a safe place or with someone you trust. We also want to teach your children how to get help. So if they're in a situation and they have kids, tell them, hey, we have to teach your kids how to get out, tell them not to get involved with the violence, and have them have a code word or a signal that lets them know, hey, they should leave or get help. The last few things that we want to do is practice how to get out of the house safely, even with the children. And we could also call domestic violence hotline periodically to assess the options and get support and understanding. But the priority, right, would be in terms of safety planning would be, right, being able to identify the patterns of abuse and being able to figure out the safe areas in the house, right? And making sure that there is a way to escape if that's possible. So those are the things that we're looking at the most in terms of safety planning, but other things, like I said, trying to keep the phones, talking to trusted friends or neighbors, and things like that. Does anybody have anything else that they want to add for that section? This is what I found from like I said, the intimate partner violence sheet.
No.
Okay. So the next thing was a definition of femicide. So I got this from the textbook, and it said that it's a term used to refer to homicide of a female person that occurs in the context of intimate partner violence. So this is when someone who's having intimate partner violence or is undergoing domestic violence, right? They are sadly killed in that unfortunate circumstance. That's the definition of femicide. The next thing I have is also, it comes from her sheet, is assessing for intimate partner violence, right? So we talked about safety planning and what to do to prepare for it and what to do in situations of it, but how do we assess, right? So the first thing that we want to do is safety, right? Assessing the safety and the safety of her children. And the only way we could do this is if we can speak to her alone. Okay, so we want to speak to the woman alone, and we need to get her alone because, sometimes in those situations, the partner does not want you to speak because they don't want you to share anything that might be incriminating of what they do at home. So we want to make sure we can assess their safety and get them alone. That's the priority. But remember, Dr. D said before we assess, the priority is establishing trust. Okay, we need to get trust before we could start that assessment, before we could assess their safety and the safety of the children, right? This person may not be so willing to speak if there's no trust established. Okay, if they don't feel safe enough to talk about what's going on. Then we can say, hey, okay, let's assess her safety and the safety of her children. Once we've gotten through the assessment, and we're looking at, okay, like, how is she? We're going to ask the first question is, does she feel safe going home, right? That's going to be our first safety question, how we could assess her safety, which is, do you feel safe going home after today's appointment? Are her children safe, right? Those are the first two things that we're going to ask. Then we're going to ask, does she need any immediate place of safety? Does she need to consider an alternative exit from the building, right? If immediate safety is not the concern, what about future? Does she have a plan, right? That's where we could start doing safety planning. Does she have emergency telephone numbers, police, women's shelter, if she needs to, go there with her children, okay? So like I said, priority, getting the trust so we could start the assessment. We want to assess her safety and the safety of her children by asking her simply, does she feel safe going home and are her children safe? Then we're looking at the other things, right? Does she need to go somewhere now? Does she need to exit the building differently? And what about future safety? Then we start doing safety planning. So all of that stuff ties together. And I definitely think she's going to be asking us a therapeutic question on responding skills because she mentioned that. Another important point that Dr. D mentioned in that outline is that the bottom line is that in most cases, the abuser will not change, and the only way to end the abuse is the victim to end the relationship. Does anybody remember what Dr. D said is the most dangerous time in an abusive relationship? What causes the highest amount of abuse? What situation?
Isn't it like when they say that they want to leave? Like they actually voice the fact that they want to leave?
When the victim tries to leave, that's when it is the most dangerous time. And she could definitely ask that on the exam. So when you say, when they said, I want to leave, they're at most risk for violence. So we have to be really, really careful for that because it could also eventually lead into, if that person is so violent, maybe to a femicide. So very scary. And other things that she had in there was that homicide is one of the top 10 causes of death for women aged 20 to 44, and more women are killed by their partners than anyone else. She also said that there is a national domestic violence hotline which operates 24/7, and all calls are confidential and anonymous, and interpreters are available in 170 languages. So I copied those too. Now, I don't know if this was necessary, but I saw this when I was looking at my notes. She mentioned this chart. So I included it in my notes. I'm not going to really read through it. It could be read through with a summary of pretty much what we've already talked about, but it could help further help us like with the assessment of intimate partner abuse and then helping with follow-up questions. So I copied this chart for use in my outline. Okay, so the next thing that we're talking about, so the whole point of that chapter was safety, right? How do we assess them? How do we make sure that they're safe? Now we're going to be talking about in this chapter, right, substance use. And I left all the pages and ATI review pages. And I also included, because she didn't specifically ask for this, but I thought it was important, is that screening is the first step in assessing if a person has a substance abuse disorder. So that means we could use our CEWA and other screening tools to see if they have a substance abuse problem. Now, the first thing that she wanted us to know is the definition of abstinence. Does anyone know what that definition means?
It's like quitting cold turkey, like completely cutting off all use of substances and alcohol.
Yes, it is no use of it, but for more than 12 months. Whereas sobriety is when we do not use alcohol or drugs at all. So abstinence is when, yes, you go cold turkey for at least 12 months or more. Sobriety is when you do not use alcohol or drugs. That is the goal, is to get them to sobriety. I wanted to put both definitions there just so that, I know it could be confusing, and I thought it would be helpful to see the difference between the definitions. So abstinence, like I said, no use of substances for at least 12 months. Sobriety is no use of alcohol or drugs. The next thing is the definition of tolerance. Now, does anybody remember what tolerance means? Well, tolerance means that you need more and more of the drug to achieve the desired effect, okay? So, take, for example, benzos that are really addictive, right? And you take, let's just say, half a pill every day. Now, right, you're getting tolerant to it. You're building a tolerance. So now I need a full pill every day to feel less anxiety. Then the pill's not working, so I take a pill and a half and things like that. So they need more drug to get the effect. And the thing that Dr. D said is that what happens is that tolerance leads to addiction. And how this works is, first we build a dependence. The dependence on the drug leads to tolerance, which leads to addiction. I really want you to know that because she emphasized that too. So dependence leads to tolerance, which we need more and more of the drug, which leads to addiction. And how do we know if someone is addicted? We know if someone, oh, you could say, I see someone unmuted themselves.
When a person is craving for the drug constantly, I don't know.
That's a good answer, but it's not the answer that Dr. D said. Dr. D said that we know one is addicted when they stop taking the medication and they experience withdrawal symptoms. So when we see like those elevated vital signs, all of that, in a way, right, that needing, they're going to have so many symptoms that they're going to need the drug, right? Like they're going to feel like they need it. So that's how we know they're addicted. So dependence leads to tolerance, which leads to addiction. And we can confirm that they're addicted when they stop taking the medication and they experience withdrawal symptoms. Now, the textbook, I just added this definition as extra, is that the textbook said diminished physical or psychological response to the effects of alcohol or illicit substances. A person develops tolerance when he or she needs to use higher doses of alcohol or illicit substances to achieve the desired euphoric effect. The next thing is that Dr. D said, let's go to PowerPoint slide 15 on health profiles and interventions for high-risk populations for substance use. So I included all of the pages, and I personally highlighted some things that I thought were important from those pages about each of the topics or the high-profile population. So I'm not going to go too much in depth, but I'm just going to review it briefly. But I included the pages that you can read under each section that Dr. D said so that you have it and you can go and like review it. So the first thing that she said is a high profile or high risk population for substance abuse is pregnant women. And Dr. D said to go to pages 400 to 404. And the two things that I saw were really important, that one of them was that Dr. D mentioned was fetal alcohol syndrome, right? So we know that can cause disability and a lot of developmental delays in children. So we need to prevent alcohol use in pregnant women because they are a high-risk population. Opioid use is also something that is a problem, and it can cause neonatal abstinence syndrome, or NAS. That is when these little neonates develop withdrawal symptoms within the first 48 hours of birth. Okay, and it can cause life-threatening seizures. Okay, so our teaching points would be, okay, we know that one high-risk population that can cause really debilitating effects will be pregnant women if they take alcohol or opioids while pregnant. The next high-risk profile or population at risk is the early ages, like middle schoolers. They're at risk for substance use. So she said go to pages 404 to 407. And things that I saw was that they said that nurses should be able to recognize that during middle school they're at greatest risk, especially if any child has friends or family members who've used alcohol in the past year. So we need to assess our younger population. And substance misuse is a major public health concern for Native American youth, more than most eighth graders in like most populations. Native American children experience alcoholism and cannabis use more than a typical eighth grader or middle schooler would. And Dr. D said, right, watch out as early as 10 and 11, they could have substance use. So our high risk or a high profile is pregnant women, substance use at an early age. The next is college students and binge drinking. So she said to go to pages 407 to 409 in the textbook for this section. And this is what specifically Dr. D mentioned in class was that, does anybody remember what blood alcohol level is considered intoxicated if they were to perform this little test on you? What the level is?
0.08.
Yes. So 0.08% or above is defined as, you are intoxicated. For women, if they consume 4 alcoholic beverages or more in within 2 hours, or for men, that would be 5 alcoholic beverages in 2 hours. This is what Dr. D mentioned, which I also saw in the textbooks in these sections. So I highlighted it here. Other things that I saw, right, is that binge drinking is kind of a part of this college student life, but it could have health risks. It could lead to physical and sexual assault, alcohol poisoning, and even alcohol-related deaths. And I also saw that motivational interviewing can be used here. And that's one of the terms that we're going to be talking about later. So we've said for high risk profile communities or populations include pregnant women, substance users at early ages or the early age population. And now we have older adults. So she said to go to pages 409 to 411 in the textbook. And Dr. D specifically, the only thing I heard was watching out for benzos. Because benzos, barbiturates, all of those drugs are highly addictive because they cause physical and psychological dependence. I also saw that the baby boomer generation is at the highest risk. It's recommended that if you are 65 years old and older to not drink more than 1 drink a day or 2 drinks in any one occasion if you are a man. And if you're a woman, you shouldn't even drink 1 drink a day. I also thought this was important. Nurses can assess for illicit and prescription drug use by conducting a thorough health history, examining urine and blood toxicology values, as well as systemically assessing older adults for symptoms suggested of either intoxication or withdrawal from illicit substances, and multiple classes of prescription medications, including those benzos, opioids, and sedative hypnotics like barbiturates. So those are all highly addictive, okay? So we want to get their medication history. That's the moral of the story. And I know she also mentioned, Dr. D, about like groups that we can mention, like Alcoholics Anonymous or Narcotics Anonymous, to help support them. So just as a summary, once again, we're talking about pregnant women as a high-risk population, substance abuse at earlier ages, college students and binge drinking, and older adults. The last 2 populations include the first one being persons who inject. So that's pages 411 to 412. Dr. D specifically mentioned that, patients who inject have the risk of HIV and hepatitis C. So I saw that there are in these pages, I highlighted things that I thought were important, was that there are exchange programs so that they provide sterile needles to help, reduce the spread of HIV and hepatitis or other bloodborne diseases, and this is called syringe service programs. I also have included that that the use of heroin is increasing in younger populations. And they said I also saw that the safest way or the most effective treatment for injection drug users is an opioid substitution, like a long-acting opioid such as methadone or buprenorphine. But I would just say, I think Dr. G just wants us to understand that persons who inject, right, also are at more risk for developing these bloodborne diseases like HIV and hepatitis C. So The last thing is methamphetamine users. We can go to page 413 in the textbook. She said specifically in class that this is highly addictive, and one hit of heroin in conjunction with what they call meth, with heroin can cause a myocardial infarction. Okay, so we have to be very, very careful. So I saw in the textbook that it said co-injection of methamphetamine and heroin greatly increases the risk of overdose and death. Um, Also that meth can be made in labs, so you can make it at home. So this can be very harmful for children. So we need to look at this. I also said to review chart 7.2 in the textbook because she mentioned like a screening tool and there was like an assessment tool there that I just thought would be interesting. I don't think it's going to be on the exam, but I included it in there because she did mention to go in that page, and that's what I saw on that page was on chart 17.2. But overall, those high risk populations, as I said, are the pregnant women, substance users at young age, college and binge drinking, the older adults, the persons who inject, and methamphetamine users. Does anybody have anything else to add?
I think you pretty much covered it.
Okay. So we talked about, right, dependence leads to tolerance, which leads to addiction. We said that we know that they're addicted when they stop taking that medication for a said period of time and they experience withdrawal symptoms. So withdrawal symptoms is one of the things that she wants us to know. What happens or how do we know someone's in withdrawal? Well, the first thing is that withdrawal symptoms start 4 to 12 hours after their last drink or drug use, okay? So the priority to ask them was when was their last drink or when was the last time they used a substance. So if they said, hey, I used a substance in the last 5 hours, I would know that they could be in withdrawal. And she could simply make it a question like that, right? It doesn't have to be how many hours do withdrawal symptoms occur, but it could be a communication question like, which of the following questions or statements that the patient says would indicate that this patient could be in withdrawal? And they're like, oh, I had my last drink 5 hours ago. Then we also want to know when we know that you're addicted, because like I said, we know if they stop that medication and they go through withdrawal, the first tool that we want to use in that first stage of withdrawal is the SIVA tool. And there's 3 stages of withdrawal. There's the first stage, which is the increase in vitals. She said this is the most reliable objective data, and we use the SIVA to confirm. So stage 1, we're looking at increase in vitals, which is the most reliable objective data. Then we have stage 2, which is nausea, vomiting, headaches, shakiness, irritability, and tremors. And stage 3 is hallucinations and paranoia. Patients by this point usually drink to relieve symptoms, and many do not get to this stage. This is what Dr. D mentioned. So they'll take their drink again or their substance use, and they will not make it into stage 3 because they can't handle the symptoms that they were getting from stage 1 and stage 2. Does anybody have anything else to add for the stages? No. Okay. Okay. So the next thing I have is one of the next questions that we're going to be asked about is motivational interviewing. And the goal of this is to try to promote behavioral change in a substance user by addressing their ambivalence, right? Their idea of, do I want to stop the drug? I do, but I don't, but I like it. So we want to address their ambivalence. And I found this from the textbook. So the textbook said motivational interviewing begins by establishing trust, being an empathetic listener, and instilling hope and positive regard. Communication skills familiar to nurses, which are the foundation of the nurse-client relationship. Once the nurse establishes rapport, brief motivational interviewing consists of specific cognitive strategies such as eliciting feelings about how the drinking behavior is affecting the student's life, noting the discrepancies between attitude towards alcohol and alcohol-associated harms, emphasizing strengths, supporting goals, and empathically supporting the student on the ways to implement change, or remaining neutral when met with ambivalence. But the whole point is, right, motivational, we want to try to make their change. We want to support them, right? And we want to be there for them and show them their strengths, but we need to establish trust first. Now, there's two medications that she really wants us to know, and this is disulfiram. It's an alcohol use drug. This drug basically causes adverse effects if consumed with alcohol. It's going to make you nauseous and vomit as soon as you drink alcohol. That's what I think you want to know. And that also, it said in the textbook that nurses should alert clients that alcohol may be used in preparation of gravies, desserts, soups, ciders, mouthwash, cough syrups, and other common household items. Clients should avoid inhaling fumes from substances containing alcohol. They cannot have anything that contains alcohol because this drug is going to be an adversive effect. It's going to make them not like it at all. Okay, it's going to make alcohol taste disgusting because every single time they'll try to drink anything or have something with alcohol, it'll make them throw up. Naloxone is an opioid antagonist that blocks the opioid receptors and basically reverses respiratory depression associated with opioid overdose. So naloxone is for opioids, whereas disulfiram is for alcohol. So naloxone is a reversal agent, and disulfiram gives you an adversive effect. It makes you not like alcohol. Does anybody have anything else to add for that?
No.
Okay. So the next thing is codependency and enabling. So codependency is a feeling. I was looking at some of the parts of the ATI, so I copied some of that and as well as some of the things that Dr. D said. So I have that substance use disorders have significant effects on family dynamics and often lead to codependency. Codependency means feelings that affect the family. Essentially, there is a feeling of over-responsibility in the non-addicted person. This is Dr. D's example. For example, let's say the husband is an abuser. The wife must care for them and engages in actions that enable the addiction. Enabling is the action, acts for others' behaviors. So, for example, in this situation, right, the wife has a codependency. She feels that she needs to take care of him or her or whomever when they're addicted. And the enabling part is that so the wife has this over responsibility to care for them, but she enables his actions, or in other words, the actions to continue substance use by, let's just say, the husband comes home drunk. This is Dr. D's example, and they cannot get up for work. The wife will call out for him, saying that he's sick. So she feels the over responsibility, which is the codependency, and the action that she does makes him or enables him and the addiction. So essentially, these two go together. So when we have that codependency, the action or the abuser becomes more enabled. So this is, not a good situation because now the wife will make sort of excuses for the husband's behavior, which will enable his behavior because she feels over responsible for him. Does anybody remember the two defense mechanisms that substance abusers typically display?
Denial and rationalizing their choices.
Yes. Can someone explain an example of these two?
Denial would be like them saying that they don't have a problem. And then rationalization would be them making excuses for it, like I have to drink because I'm stressed out or something like that.
Perfect. Yes. So I don't think she's going to ask us to identify them, but I appreciate the examples because it's good for us to know because you never know, right? She could say like, which of the following or would be an example of the defense mechanism of denial, and it's good to still be able to remember what an example of the two would be. But yes, denial and rationalization are defense mechanisms typically seen in substance users. Now, how can we promote primary prevention for substance use disorders? Well, we could educate, right, on what substance use can do and the effects. Some other things that I saw would be, I think this was from ATI, increasing public awareness, particularly among young people, regarding the hazards and risks of dependence associated with substance abuse, like public education campaigns, school education. So, education, encourage development of life skills, or assist in the formation of parental action and awareness groups like Mothers Against Drunk Driving. Okay, so all of this has to do with some sort of education. Now, this I just added, it's not a part of the exam, this one on screening tools, but I just wanted to include them since she said screening tools were the first step in assessing for substance abuse users. So I included the CRAFT, which is for adolescents who experience substance use, CAGE, which is for a geriatric population, and the SIWA, which is a withdrawal indicator, which we mentioned when we were talking about indications of withdrawal. So the next thing we have is a genogram. Does anybody know what a genogram is?
Wouldn't it be kind of like a family tree, like a graph of basically like all family relations?
Exactly. It's like a family tree, where it talks about, right, how they died, when they were born, from different generations. But it's not like genes. We're not looking at the genes. It's just like a big picture of what happened. But it could tell us biological information based on family health and illness patterns, right? Like this family is very prone for diabetes or heart or cardiovascular issues. Ecomaps is a diagram used to identify direction and intensity of family relationships. Basically, we're looking at family interactions with other groups and organizations. But the definition from the textbook was that a diagram used to identify the direction and intensity of family relationship between members and or community institutions of importance to the family. So ecomaps, how families interact with others. Genograms, basically the interactions within the family based on family health and illness patterns. She said for this, there will be 2 questions on family burden. Now, something that I saw from ATI is that family caregivers need education and support. And the definition that Dr. D provided was that caregiver burden is significant stress on the family member who assumes the primary responsibility of care for another family member. Does anybody have anything else to add for this? I'll take that as a no. Okay, so the next thing is the family interview, which is going to be 1 question. And like I said, always with these interviews and assessments, the first thing we need to do is gain trust. After that, we have in the textbook, I found this, which are the 5 leading principles, which is what one of the slides were. And first is the mannerisms, right? We want to introduce ourselves, develop trust. I think it's going to be a trust related question. Sit at the same eye level, use appropriate attending skills. She might even ask us, like, how should I sit with a person to conduct a family interview? Okay. The next thing is therapeutic conversation. Focuses on the client's family thoughts, feelings, and behaviors. Okay. So we want to talk to them, right, in a way that can validate their feelings. We can use ecomaps and genograms. These are tools we already talked about to help see the relationships between the families and other people. We can ask them therapeutic questions such as tell me more about blank, open-ended is therapeutic, non-therapeutic would be a closed-end question like is this couch red would be a closed-ended question. That would not be something you ask them, but that's just an example. There's only one answer to that question. The next thing would be acknowledging family strengths. So what works in the family? But our priority is introducing ourselves and gaining trust so that we can perform the family interview. The next thing I have is characteristics of a healthy family. Now I have all of these listed, right, from the ATI book on what are characteristics of healthy families. But can you all just give me some examples of what you think would be an example of a characteristic of a healthy family?
Good communication,
Mm-hmm.
respect,
Mm-hmm. Anything else?
They trust each other.
Yeah, right? Like, I know sometimes it feels like we have to sometimes memorize a lot of things, but like the examples you gave are examples of a healthy family. And what it says here from ATI is that they're able to communicate and listen to each other. There is affirmation and support. There's respect. There's a sense of trust. They can share humor together and interact with one another, have leisure activities together, maybe even share a religious foundation. Privacy is respected. Everyone shares some sense of responsibilities. There's traditions and rituals, and members seek help for their problems. So, this is examples of healthy. So, the question might simply be like a true or false, or, is this an example of a healthy family, or which one isn't an example of a healthy family? The next thing I have is crisis and transitions. It's on ATI review book page 53. So I copied everything that was there and added in any notes that Dr. D said. So in the ATI, it said that a family crisis occurs when a family is not able to cope with an event. The family's resources are inadequate for the demands of the situation. Transitions are times of risk for families. Transitions include birth or adoption of a child, a death of a family member, a child moving out of the house, marriage of a child, major illness, divorce, loss of income. Transitions require families to change behaviors, make new decisions, reallocate family roles, learn new skills, and learn to use new resources. Dr. D also mentioned that a crisis should be short term, and we should ask them how do they perceive what's going on. Does anybody have anything else to add? Okay. But yeah, so crisis, short term, if they're in a crisis, they cannot cope, and any sort of transition or change that's going on in their life can put a family in crisis. Now, does anybody remember what Dr. D said is a definition of the term enmeshment? Well, this is where everybody speaks for everybody. Nobody has their own voice. And Dr. D mentioned that an issue that you typically see enmeshment in is in a situation where there is anorexia nervosa in a child because they are starving themselves because of disturbed body image. And in this scenario of enmeshment, right, they can't speak for themselves. So they feel that the only thing they can control is what they can put into their body. So they have no control over anything but what they can eat. So that's why the problem of enmeshment can be very serious. And our goals is that we want every family member to be their own person with their own goals, and we need families to let their children make age appropriate decisions. So that's it for that chapter. The next thing I have is on chapter 20 about disasters. So the first thing she wanted to know was a definition of a natural disaster. But can anybody give me an example of what a natural disaster would be?
Earthquakes, tornadoes, volcanic eruptions.
Yes. So, natural disasters are a result of naturally occurring events that have an impact on the environment, the economy, and the people who live in the area. Examples include earthquakes, extreme heat, floods, hurricanes, landslides, tornadoes, tsunamis, wildfires, winter weather. But overall, all of these conditions are threats to health. That is the definition from the textbook from that first paragraph. The next thing that you want to know is disaster management. So all I saw for that slide was these three things: pre-impact, impact, and post-impact, which is pre-impact or what's going on before the disaster, what happened during the disaster, the impact phase, and post-impact or after the disaster. Does anybody have anything else to add for that section? Okay, so then I think I'm on the right track. So the next thing is, how do we evaluate a disaster response? She said, I wrote in my notes, she had to read pages 492 to 469 in the textbook. But I wrote extra things, but I'm gonna just highlight the thing that's actually for this question so I don't like keep you here longer. But I put the stages of the disaster, like how it works, like prevention, preparedness, for the purposes of reviewing it for myself to understand. But she wants us to know this section, which is the evaluation of a disaster response, which is from our ATI. So the first thing that we need to do is evaluate the area, effect, and level of disaster. What happened? The second thing is create an ongoing assessment and surveillance reports. Surveillance means looking out to see like what's going on, and creating documentation on it. So first we figure out what's going on, then we make an assessment. Then we will evaluate the efficiency of the disaster response teams. And then the fourth thing that we do is estimate the length of time for recovery of community services such as electricity and running portable water. That is the section that she wants us to remember. But like I said, I added a little bit more. But okay, so the next slide that she wants us to know about is PowerPoint slide 15, and it's titled The Role of Nurses in Disaster Management. So the first thing is that public health nurses are first responders. That's something that Dr. D emphasized. And something else that you said is the priority is assessing community needs as they unfold, right? As a nurse, our priority is to assess, right? When we're like evaluating what happens, like in the evaluation of disaster response, we're assessing the situation. So we always need to assess first, okay? So we assess first, then we conduct surveillance for communicable diseases, right? And surveillance, like I said, is a process to document and track changing information to prevent injury and illness. So we first assess, then we conduct surveillance, then we prevent the control and spread of disease. Remember, a public health nurse is supposed to prevent. We want to prevent illness and promote health, and we want to reduce the risk. So by primary prevention. So we're assessing, we're doing a surveillance, then we prevent and control the spread of disease. We maintain communication channels. We organize and manage points of distribution. Provide on-site triage as needed. So the thing that Dr. D said here is that we want to save the people that have the highest priority, not dead or dying, people who have a chance of survival but need immediate care, people who are dying. In those situations, we just make comfort measures, but we have to help the people that we can actually save. We must manage behavioral responses to stress, ensure the health and safety of self, colleagues, and the public, and document the events. But our priority is to assess, okay? Assess the community's needs. And I added this table on the color coding for pre-hospital triage, just as there to help kind of visualize like the different types of tags and what it means in terms of what's critical, what's urgent, what's delayed, and expected to die. I just included that there. So red is critical, then those are the ones that we need to see immediately. A yellow coding would be they could wait, a little bit. Green, they could wait a couple days, but a black tag means that they're gonna die. Now, does anybody remember what a point of distribution plan is or an emergency dispensing site? Well, it's a centralized location where the public picks up emergency supplies, including food, water, and medications if necessary following disaster. So it's basically a place where you can get things if you need. The plan details the staffing required and procedures to be followed in a setup and deactivation of the point of distribution. So we need to have the right procedures, the correct setup, and know how to, stop this when we need to. And this comes from page 494 in the textbook, the first two sentences. That's what Dr. D wrote. Now, the next thing is she wanted us to go to page 500 and look at the first sentence. So I copied that first sentence about public health nurses as first responders. And it says public health nurses nursing practice focuses on the provision of comprehensive public health services to ensure that community members have access to preventative care, immunizations, safe food and water, and assistance with services that may go beyond medical needs. Okay, so like I said, we are those first line responders because we want to prevent. Remember, we try to prevent care by giving immunizations and education, making sure they have food and water, and giving them all the services. That's how we act as the first responders. Now, triad, she told us to go to table 20.4, which I copied into this. And I also copied the definition that I saw about simple triads and rapid triads, a SMART model. And it says that basic triads in a rapid treatment or START is a simple I put START into SMART, whatever. Is a simple hospital triad system that was developed in California to assist emergency responders in earthquakes. Evidence-based and field-proven, the system separates injured people into 4 groups according to the severity of their injuries or illnesses. So there's this table, which is 20.4, and it's 0, which are those who have died. That's like our black tag, right? Injured and required immediate transfer, that's like our red tag. 2, injured and who can wait to be transferred, that's our yellow. And injured with minor, less urgent needs would be our green tag. Does anybody have anything else to add? Okay. So the next thing I have is the role of nurses in chemical disaster. And she said to go to page 510 and go to the first paragraph. So this is what I got from the slides about this topic, and the top part, or part A, is what I got from the textbook. So in the textbook, it said that in the field, the public health nurse's response to a chemical incident is summed up into 2 words: act quickly. Hazmat experts report to the hot zone on notification of release of the chemical. Now, this is the green thing I highlighted is the priority here. The nurse may be asked to report a temporary evacuation site where people exposed to the chemical are awaiting triads. Before we can go get these people to their evacuation sites in a chemical disaster, we must don PPE first. We need to put on protective equipment for ourselves. That is our priority. Then we can do everything else. Getting them to the area, assessment of the victim's ability to breathe, and looking at their airway and respiratory function, keeping the victims in a sitting position with, loosened clothing. And if this patient cannot sit, make sure the torso is elevated, but our priority is donning PPE. And then after that, we assess breathing. So airway is our priority for this. In the slides, it said stay or go. Evaluating factors include the following. So hazardous material involved, the population threatened, the time span involved, the current and predicted weather patterns, because it can spread more quickly on a windy day, and the ability to communicate emergency information. Like I said, I just included that because it was a part of the slides and related to this topic. So the next thing is dust on clothes. So imagine we have radioactive dust on our clothes. What do you think might be the first thing that you should do?
Use PPE stuff to cover and protect.
Yeah, we want to cover and protect ourselves as someone. But what if someone comes in, let's just say, before we even go to move them, and we're like, hey, we did all that stuff in the beginning. What should we do after, right? If someone kind of comes in and we see that they might have had radioactive dust on them, what should we do for ourselves after everything? So if we have dust or we've been exposed to someone who has dust, we want, as soon as we get out of this area, right? Because we're gonna don the PPE before we could do anything with them, right? We protect ourselves to make sure, we could assess them and do whatever. After all that's done and we're done, dealing with all this, we have a couple of things to do. So steps to follow a radiologic disaster is leaving the area, getting to the nearest building, covering your nose and mouth, but we must remove our clothes and seal them in a double thickness trash bag, okay? Because we always must assume the dust is radioactive. So I would say this, since this is the question that she mentioned, I would say it would be removing our clothes, putting them in that double lined bag, and taking a shower so that we can decontaminate. Then we will clean and cover any open wounds and listen to the radio, watch the TV, or to assess what's going on in the state. Now, I also got this from the textbook, which said community-based nurses are not called to actual location. However, nurses working in a receiving station may observe dust on arrivals. It must be assumed that dust on victims is radioactive. PPE should be worn as well as a radiation badge to measure personal exposure. People should remove the clothing and be deferred for decontamination, right? So the question's like, oh, a nurse suspects, a patient comes in with dust and maybe, they're on their way home. What should the nurse do? They should remove their clothes, put it in a double lined bag, and shower. Cover any sort of open wounds. Stable victims should be moved out of the area quickly, and the people in the surrounding facility should be notified. Make sure there's appropriate documentation. And make sure that we have protective actions available to the public. Then she said there's going to be a question on therapeutic interactions, which is going to be a communication question. Now we have agents of bioterrorism. We can have pages 75 and 76 printed and available with us on the exam. This is going to go over the agents of bioterrorism, and there's going to be 10 questions on this, which are going to be true or false. So she said we're going to be reading it, from the paper. It'll be like, oh, true or false, like anthrax is a category A. Like, it's going to be things like that, but we're going to have it there. And she said we could highlight and stuff. Now, another thing that's on page 76, which I did clarify with her, is that it also includes the levels of prevention, 75 and 76. And one of the questions on our test, besides the true or false, is going to be primary prevention for bioterrorism. And she said that's okay. So we can have everything, including the bioterrorism and the levels of prevention, which is pages 75 and 76, which she said we could have. So the primary prevention, I also wrote it down in here, just so I have it so I could read it over, is that the ATI said to prepare with bioterrorism drills, vaccines, and ensuring availability of antibiotics for exposure prophylaxis, design a bioterrorism response plan using the most probable biological agent in the local area, identify the chain of commands for reporting bioterrorism attacks, define the nurse's role in the event of bioterrorism attack, and set up protocols for different levels of infection. Like I said, this is going to be on page 76 in the printed sheets that we have, but I just wrote it out just to have it. Now, another thing that she said is that we need to know the epidemiological triangle. We actually have to know these three terms. So we need to know, we're not going to have access to the printed page for this, but this is on page, actually, it's not 25, it's actually 23 in the ATI book. But agent is the physical, infectious, or chemical factor. So the agent causes the disease. The environment is the setting or surrounding that sustains the host, okay, like where they are. And the host is a living being that is an agent or the environment influences, or who is it susceptible to the infection. Now, we could have page 25 on the exam. So page 25 is the modes of transportation. I emailed Dr.D to ask because I wasn't sure if it was the epidemiological triad or the modes of transportation, but everything that talks about modes of transportation, including like airborne, vector-borne, all of that stuff, we are allowed to have that on the exam with us. But, okay, those are the things. So 75 to 76 and page 25 we can have with us on the exam. The next thing is she wants us to know, that's, not in any of the pages or that we have available, is a definition of an incubation period. An incubation period is the time period between initial contact with the infectious agent and the appearance of the first signs and symptoms of the disease. So this is when you get into contact and before you have any sort of appearance like of severe illness. Now, I'm not going to go crazy into this right now because we have like definitely a decent amount here today, and I don't want to keep us forever. But she wants us to know the symptoms of syphilis. Now, pages 315 to 316 is like a lot of paragraphs, so I wasn't going to just copy that into my notes. I figured I would read it and, like help it to refresh my mind while I'm looking at this. In this notes that I've made, I included the chart from the STI and STD chart that she provided, and I also screenshotted the lecture notes that she gave us as well. So I included both of those. So that's why I'm not going to go like reading into it since we all have it. But just so we can get an idea, I'm going to read this little chart. So syphilis, according to this STD and STI chart, is a bacterial infection entering the body through breaks in the skin or lining of the genital area. Over time goes to damage internal organs like the heart, brain, and spinal cord. So we're talking about a bacterial infection that gets into the body. How you get it? Well, by having vaginal or oral sex without a condom with someone who has the infection, or from mother to baby across the placenta, also called congenital syphilis. The symptoms are typically a painless ulcer, usually on the genitals, later swollen glands, a rash, and even hair loss. Okay, so a painless ulcer. Treatment, it's a bacterial infection, which means we give antibiotics followed up with a blood test. And for partner notification, they must be tested and treated if positive. Current health regulations advise no sex until you are cleared. So this is the summary of syphilis. Like I said, I included the screenshot of the notes that Dr. D sent us. And yeah, that's pretty much it for the final review.